what is our purpose as sleep techs, right? We discussed on chapter 1 and 2, we discussed a little bit that our purpose really is to be the extension of the sleep specialists, right? And these patients that are coming up to see their doctors, they don't directly go to a sleep specialist. They go and see their primary care, their family medicine, their internal medicine, maybe their cardiologists, right? And they complain about, I'm always tired, I'm sleepy, I snore, or I have this weird feeling when I wake up, I'm gasping for air, I feel like I'm choking. So all these regular and common signs and symptoms that sleep patients have, they usually go see their primary care first and not the sleep doctors. And then they will get referred into the sleep lab or the sleep clinic in order to get diagnosed. So that's when our roles begin. And in some labs, we are part of the day shift. Okay. So I want you all to remember that sleep technology is not just night shift. We also work during the day, right? So during the day, we could be assisting in the scheduling and getting the patient's referrals. And I actually have our lead tech. We have a lead tech, and then I have the night tech, and then I have day techs. Okay. The lead tech, I ask him to look into all of the patient's orders. So we have our sleep doctors, we have sleep fellows, we have nurse practitioners that also see patients for sleep, and they will create the order where, for example, this patient was referred into the sleep clinic, right? And they'll go to the consult or the referral, and they will read, okay, Mr. Abdullah here has issue falling asleep at work, having headaches, etc., etc. Patient has history of hypertension, right? Patient is over 50 years old. Then, so the sleep doctor or nurse practitioner will order a home sleep testing, right? And so they'll send that order, and our sleep tech, our lead tech, will look at the order, and the lead tech will go and look at all the orders from the other doctors and nurse practitioners. And sometimes the lead tech will catch an order that doesn't make sense or is missing something. So the lead tech now, his role is to question and ask that ordering doctor or nurse practitioner. Say, hey, doctor, this patient has history of COPD, but you only ordered a home sleep testing. Shouldn't the order be an overnight sleep study? Because if this patient has probability of OSA, yes, because of hypertension, but there's one missing point here. This patient has COPD. So when you have a patient that has COPD, usually you will want to do an overnight sleep study because of the comorbidity. Okay, the comorbidity, which is COPD. Okay, you don't want to do home sleep testing to patients who have comorbidities such as one, COPD, two, obesity, hyperventilation, three, neuromuscular disease, right? Four, maybe morbidly obese. So there's many other things to consider when ordering home sleep testing versus overnight sleep study. Now, do you see the role of a sleep tech during the day is a little bit different, right? It's a bit more engaged. And that's why it's important for you all to understand that when you are in sleep or just getting into sleep, there are so many other things that you need to learn that can help you also get into the other types of roles as a sleep technologist, right? In the future, you can be running during the day, scoring sleep studies. You can be the one helping the doctors and nurse practitioners go over the charts or the patient records, provide the assist in providing clinical management to patients, etc. All right, let me stop there. Any questions? No? Okay. I gotta hear some yes or no, okay? Otherwise, when you're talking by yourself, you don't hear anyone talking back, you feel like you're by yourself. And no, I'm thinking probably all of you are already asleep. But anyway, Is that clear?
Clear,
Yeah.
sir.
Okay, good.
Yes, sir.
Clear, sir.
Very good. Now, don't be shy, okay? Again, don't be shy to respond. And common conditions evaluated in through polysomnography are mainly, of course, sleep disorder breathing. All right. So to give you an idea of the typical umbrella for sleep medicine, right? Sleep medicine is the overall umbrella of what we're doing. We're under sleep medicine, correct? So under sleep medicine, you have different types of patients that we see, right? In one area, you have the sleep disordered breathing. So these patients, they could be normal during the day, but as soon as they fall asleep, they have issues with their breathing. This is when you have OSA patients, mixed apnea patients, right? Maybe hypoventilation patients, right? They can have restrictive lung disease, right? So these are your patients that have issues breathing, and typically you diagnose them, right? The doctors diagnose them with whatever is appropriate. Well, majority, of course, are obstructive sleep apnea, but some patients have central apnea, right? And others have obesity hyperventilation syndrome. Now you have another type of grouping of patients, which are your insomnia patients. These patients have issues falling asleep, staying asleep, or waking up too early. So they are related to your circadian rhythm disorders. Circadian rhythm is that they do not have a normal sleep-wake pattern, right? Some of these patients, maybe teenagers, they always sleep in, right? Meaning sleeping in, meaning sleeping late in the during the day, especially on the weekend, right? I have two teenager daughters. One really, when it's Saturday, yeah, she'll wake up really late. Mm. So I have to kick her out of bed. But that's their pattern, right? And will have, some have early phase syndrome, some have delayed phase syndrome, some have irregular phase syndrome, or irregular rhythm disorder, where they don't really have a clear pattern. They can sleep at 1 a.m. The following day, they can sleep at 9 p.m. The next day, they'll sleep at 4 a.m. So those are your typical circadian rhythm insomnia kinds of patients. Now, there's another group of patients that are your narcoleptic patients, narcolepsy, right? So these are also very different. You address them differently, you diagnose them, and then you treat them differently. Okay. And then you have the movement disorder patients, like movements, soliloquy or sleep talking, their parasomnias. Okay. So as you can see, we have a variety of patients that will go to the sleep lab to get diagnosed, but that we have to deal with them because everything that they are suffering from is related to sleep. Okay. Clear? Now, the components of polysomnography, as you all know, majority is the brain, right? Why? Because the focus really is what's happening. What is happening in their sleep? Do they fall asleep quickly, right? When they are asleep, do they wake up often? And when they wake up often, what are the causes of their interruption? So EEG is the main component, is the main parameter that we measure to figure out whether this patient has normal or abnormal sleep wake pattern. And if they have abnormal patterns in sleep, why? Is it because they have frequent arousals? They wake up a lot? Then, if they wake up a lot, what are the causes of their arousals? Is it snoring? Is it respiratory related, right? Do they have apneas? Do they have hypopneas? Do they have reras? Okay. Or is it spontaneous arousal? Do they just all of a sudden wake up and we don't know why? So we have to figure that out. Now, EOG, electrooculogram, are your two monitors for the eyes, and that helps us determine whether the patient is in what stage of sleep. Anybody? What do we use the EOGs for? Come on,
REM,
people.
sir.
Identity.
RAM,
REM.
good. Yes, RAM. So we use the eyes for RAM, okay? However, We also use the eyes to make sure that is this patient awake, right? Because there is REM, as in rapid eye movement, but there's also reading eye movement. So remember that there's a difference, especially in the description. And one is awake, right? The reading eye movement is awake. They look alike. They really look alike. But you have to look into the EMG. You have to look into the muscle activity. Because in RAM, that should be minimized or absent, right? When you get into RAM, usually you lose all muscle tone. Okay. Some patients have some muscle tone. That's why we have two types of RAM, which is phasic and tonic RAM, right? We will discuss more of that later. But if you're taking notes, then take notes. Okay, I will also I'm recording so you can review these things and then we can elaborate further. But going back to EOG, we also use the eye movement to ensure that this patient is in REM, awake, or are they going into N1? Remember, the EOG will help us determine if the patient is going into N1 by looking at a pattern called SEM, or slow eye movement, right? Slow eye movement, instead of having really fast activity that the eyes will flick up and down or in phase or out of phase, the EOG channels will show the eyes as a rolling. It will look like respiration, right? It will look like sinusoidal pattern. And when the eyes do, that's a sign of slow eye movement, meaning they are getting into N1 sleep. All right, clear? Then EMG, of course, are your muscle tone monitors. We put usually three, sometimes just two, but we put these sometimes four. So we put this EMG on the chin, right? And we will talk about that more later. We put EMG on the chin, and there is also an alternate location by the side of the ears towards the face. It's by the jaw, okay? By the mandible, all right? So that's to monitor muscle tone, whether the patient is one in REM, that can help, whether the patient has bruxism, right? If the patient is bruxing, so bruxing is grinding of the teeth. So as you can see, can you see my screen here? See this pattern? If this is a chin EMG channel, the bruxism will look similar to this, but this is more like snore. Bruxing, usually when the patient grinds their teeth, you will also see the muscle activity on the EEG channel. Okay, because when you bite down, that muscle activity creates a muscle tone also increasing on the EEG channel. So it will bleed into the EEG and even EOG. Okay, it's not isolated on the chin. The other EMG muscle or EMG channel that we have is the leg, right? Or the legs. And does anybody remember which part of the leg we put the sensors at? What is it called? What's the muscle that we use to monitor leg movements? Anybody?
Tibialis anterior, sir.
Very good. Yeah, I hear two of you talking. Anterior tibialis muscle. So remember ATM. Okay, where do you get your leg movements? From the ATM. Okay, the anterior tibialis muscle. So which we will pull up. And when you do anterior tibialis muscle, and your doctor also said, hey, I want you to do a sleep study tonight. We have this patient, and the patient's complaint is that they act out their dreams. So sometimes they'll walk, sometimes they'll kick, but sometimes they'll fight. They'll punch their bed partners. So I don't know if that happens to you guys. If any of you have bed partners or married and you end up punching or hitting your bed partner. I actually did that to my wife, right? Promise I was asleep, but I was dreaming that I was being attacked by a big black man. And so this guy was big, he was towering me. And so when he was bullying me, I punched him. When I punched him, I woke up because I actually slapped my wife's butt. Fortunately, she was facing away from me, so I slapped her butt. And so she woke up because I heard it and I felt my hand hit her. So she screamed and I woke up. And it was because I was dreaming. I was acting out my dreams. And so it's scary that sometimes it can happen. And there is a type of sleep specialization called sleep forensics. Okay. And has anybody of you heard about sleep forensics? Anybody?
No idea.
Okay. I will introduce you to sleep forensics right now. So sleep forensics is a particular science dedicated into investigating bizarre, unusual sleep cases. This guy right here, Michelle, he has been coming into our meetings. I am part of the network of Asia Pacific sleep specialists, correct? Anybody know that? NAPS? But has been presenting in our sleep conferences. So I will introduce you guys to this world so that maybe next year you will join me. This year we just came back from Malaysia in May, right? So we have a 2-day agenda. In fact, that's when I met Hilmi. Shout out to Hilmi. So these are our speakers, okay? But we do this yearly. Next year we'll be in Hong Kong, right? But I want you to think, where is that? So we have had sleep forensics in our meetings. And so this is a very interesting topic. Okay. But we do provide many other topics that you can learn on a 2-day program. We do a lot on, of course, PAP therapy, oral appliance. You can see here, sleep and violence. That's Michelle Borneman. So sleep forensics is a very interesting science within sleep medicine. He is actually a pulmonologist, but has been a researcher in sleep forensics. Okay. So there's a lot more to learn. Really, when you get into sleep, you will realize how big this medicine is because there are branches in sleep that are still continuing to expand. The recent discussion on COMISA, complex insomnia, meaning to say you have a mixture of obstructive sleep apnea with insomnia. And that's why you have patients that are first doing good with CPAP. All of a sudden, they'll start to become sleepy, even though they have normal AHI. So come to find out, they're actually developing complex insomnia. Okay? So I don't want to overburden you with all this information, but I want you to get a taste of some of these items in within sleep medicine that are not commonly discussed. Okay? All right. Let me stop there. And questions? No questions? All right. Back to the topic. Okay, good. Thank you. Now, as you all know, we also monitor heart rate and rhythm, right? We only use really one channel. Sometimes some sleep systems we will have two channels for EKG. Alice, Philips Alice 6, Alice 5, G3 system, usually you'll have two channels for EKG or ECG. Now, we don't have many sensors that we place on the patients. We usually will have two or three. If you're doing any type of research, like where I am working now in the University of Southern California, the lab used to do research and they added 5 EKG electrodes. So they're monitoring multiple angles of the heart. But that's not common. The most common in sleep, anywhere you go, is just one channel. So you will have maybe 2 to 3 electrodes that you'll place on the patient's chest. Okay. And you're monitoring really common arrhythmias. premature ventricular contractions or PVC. You monitor PACs, bigeminy, trigeminy, and triplets, VTAC. Okay. Now we will discuss that on a separate class. We will go a little bit deeper on into arrhythmias and identification. All right. Moving forward, let's go into EEG. As EEG is very crucial when it comes to any polysomnogram studies, right? Any sleep studies. Simply because the sleep, the quality of sleep, right? The understanding what interrupts sleep is the goal for us, right? And for the doctors. The patients will experience difficulty sleeping or that they will wake up tired. And eventually they'll complain that why am I experiencing this on a nightly basis? Some patients will have help because they have spouses or bed partners that will tell them, hey, you snore at night, or you stop breathing, or you're screaming, or you're moaning, or they call it cataphrenia, right? You're doing this and that. So they have somebody that witnesses what might be happening to them at night. But other people, they don't, right? They sleep by themselves. And so they don't know what's happening. They're just never refreshed. So that's when it begins for them to question about their sleep. But many patients out there undiagnosed, they don't ever ask. You believe that? Right? They won't even ask. I think I'm just getting older, so I will never sleep better than how it is right now. There's so many patients out there that are still not being seen because they don't understand that their sleep pattern is actually compromised. So our goal in sleep as text is to ensure that the recording is optimized, that we provide the best possible overnight studies or even home sleep testing for these patients. Simply because if we do a poor job in putting on the electrodes, we don't even measure. What's the measurement called? What's the system called? Anybody? What do we call the system of measurement for the head in EEG or sleep?
I-10-20 system.
Very good. Very good. Who was that? Chris?
Aisha.
Aisha. Salam, Aisha. All right. Good to have you. Now, let's pull that up. So she said I-10-20 system of measurement. Because I want to make a point, right? Oh, don't pull this up. This is crazy EEG. That's usually you do this if you're doing research. We don't need that. The sleep is actually the least number of electrodes. So when we do I-10-20, right, we measure from the nasal bridge all the way to inion to where you feel that bump in the head. And I have a video on that I will share with you guys. But the importance, if you look at this, if you don't measure and mark, you can potentially put the F3 somewhere here, C3 off also, or even occipital, maybe a little bit too low. So then you will not get the appropriate quality of the signal of the brain that you need. So in essence, if you don't measure and mark and you put the electrodes on a suboptimal location, you will affect the quality of this sleep study, particularly the staging, right? The stages of sleep. And so remember this because in sleep, this is easy. In sleep, we don't have to put these entire set of EEGs into the patient's head. Okay? So let me give you an example. This is a normal EEG placement, and I need you all to memorize this. I need you all to know this. This should be like a hammer if you're a carpenter. This should be a stethoscope if you're a nurse or a doctor, right? EEG measuring should be easy for you. So you have to memorize it if you can apply it every single night. Why? Because you have to get the spots. But in sleep, you don't need all of these spots. You just need F3, F4, C4, C3, O1, O2. So that's just 6 placement that you need to really capture. The other parts of the EEG that you add sensors to are your A1, A2, which you don't need to mark, right? Because it's just behind the ears. And then the forehead to put a ground. But see how easy it is for sleep to measure and to apply the electrodes. But then if you do use the I-1020 measurement system, you place the electrodes correctly. You have them on the right spot where it can pick up the optimal signal from that particular part of the brain. Okay? You get my point? All right. Now, we will have, actually, I have let me know when you guys are ready. I can give you guys the access to the I-1020. All right. Is everyone here? I don't think that you guys have access to the 1020 yet. Can you confirm? Can I hear people respond right now? Do you guys have access to this I-1020 video or not? Oh no.
Yes.
Not yet.
Not yet?
Yes.
Yes po.
Oh, yes? Okay. So some of you don't, right? Some of you don't?
I think I don't have the access.
Okay. That means, so message me after the class, yeah? So I can share it with you. Or I can do it right now. Oh, there we go. Look. So who here? Hilmi, who else? Who else doesn't have access? Is it Kent?
Can't I don't have yet.
Okay. Where are you? Oh. What's your email, Kent?
I will type it, sir. Wait.
Okay. Type it on the, okay. On Zoom, yeah? Got it. Thank you. That makes it easy for me. Who else? Did I miss anybody? If nobody,
Me,
then,
sir, please.
oh, who's that? Chris?
Please, sir.
Okay, Chris.
Ah,
I,
that one.
yes, thank you. Okay, anybody
Thank
else?
you, sir.
No problem. So I have 2 videos on this. One, it was me, the other one is my wife. Maybe you will want my wife instead of me. She's more pleasant. But I also have one with me. So you'll see how she'll prep the scalp and where she'll measure and mark, okay? Very clear. It's a long video, but when you get used to this will take you less than 5 minutes. When I go really fast, I can finish this in 3 minutes or less. Okay, just so you know that this doesn't require, because this is what, 15, 20 minutes of recording because she's going really slow. Okay, but once you have this down, it's really easy, guys. It's really easy. Okay. All right. Moving forward. Now, let us move to the next, which is the EOG, right? EOG. When you put EOG, you put it on the outer canthus, right? Outer canthus means the corner of the eye. Let's pull up a picture, a video, because so it's important for us to, okay, let's look at this dude. Okay, so look at this corner of your patient, right? This is the outer canthus. So you go from the outer canthus to 1 centimeter below it. So this is good placement, actually. Very good. To the right side up, left side down. Okay? Again, right side up, left side down. And the idea here is if this patient turns their eyes to the right, You're talking about the retina in the cornea, right? The retina will get closer to the patient, the cornea will be away because the retina and the cornea have opposing polarity. One is positive, one is negative. So we will go more deep into that later. But as the patient turns their eyes, one positively charged portion of the eye will get closer to the electrode, while the negative portion of the eye will get closer to the other electrode. So this is how you end up with polarity. This is why you end up with the fluctuation on the EEG, where you can see an in phase, out of phase, right? This is how you can see this upward or negative deflection and a positive deflection, and they're opposing, right? This is out of phase because the other channel is going the opposite direction. So you can see the eye opening or closing by having this polarity, right? This is out of phase and in phase. In phase is they go towards each other, out of phase away from each other. Is that clear? Claro?
Yes, sir. Yes,
Okay,
sir.
good. Sorry. All right. Now, oh, so when we have the eye movement, when you have the proper location of the eyes, you will affect the quality of the eye deflection. Okay. And there is also an alternate method because sometimes your patients might have, let's say your patients have a glass eye, right? Or one eye is missing. They're blind. They had accidents before where they're missing one eye. You will still put it as if they have an eye on either left or right side. Okay. You will act as if it's still there. But for sometimes you have some patients that have injury where you cannot put the correct lead placement because they might have a scar or a wound, right? They might have a cut. So you have to choose an alternate method. So you can do that in sleep. Okay, you have options. Now let's move to electromyogram. EMG is to show increase or decrease in muscle tonicity, right? Atonia is loss of muscle activity. And so it's important when we are trying to identify REM, but also in just the first stage of sleep, N1. You know, when you first start the study, look at the background of this slide, right? It's a lot of mess, this is dark. This is dark because of muscle tone, correct? This is dark because of muscle tone. But once this patient calms down and they actually sleep, the muscle tone should diminish. And that's how you can also help identify that this patient is now asleep. Okay. There's a few things that you can use to help you identify the sleep pattern. Remember, you might be the recording tech or you might be the scoring tech. So if you're the scoring tech, you don't want to guess, right? You don't want to guess, oh, is this patient asleep? I can't see it because I don't know. It's hard to understand the EEG, right? So it usually so it's a result of the suboptimal placement of electrodes, right? Or too many artifacts. So if you are a scoring tech, you will appreciate somebody, a recording tech that have a really good electrode placement. Okay, because everything will be so clear for you. It's easy for you to score. Okay. Now you can also miss some activities if you don't have the right placement. One of the more important things aside from muscle, which is related to this, is the snoring channel, right? The snoring channel is usually labeled as EMG2 or part of the EMG, but it's not really an EMG channel, right? It's not a muscle activity. It's actually vibration, right? So this microphone that we use in sleep, let me pull up that muscle. So here, so this is typically your muscle, your snore microphone. This is too directly into the Adam's apple. You don't need to put it right there. Okay. You will feel the Adam's apple right, in the middle, and then put the microphone on the left or the right side of the patient. If you put your finger here, don't choke the patient, just put your finger, all right, and tell the patient to talk or just try to snore. If you ask them to snore, you will feel the vibrations here because this is where the voice box is. Okay? When you do that, you apply your snore microphone there, you will get really good signal. Okay? And if you don't get a good signal, you can reposition, but you never start your study without getting the appropriate signal showing in your screen. Okay? You don't move forward until you get that snore microphone working. Otherwise, you are compromising your sleep study. All right, for leg movements, the same way. Yeah, let's look at the anterior tibialis muscle to make sure that we're all on the same page. So the ATM is important, right? When you go for the ATM, so just look for the shin bone and then look at the leg halfway, okay? This is too high, right? You will still get signal, by the way, but this one looks like the electrodes on the bone. So you're not going to pick up good signal there. This is the muscle right here. If you touch your own shin bone, go to the left or right side of your shin bone, so anterior, right, towards the outer portion. And the front, but towards the outer portion, not the interior, not the interior part, but the anterior part, the external, right, towards the outside. So touch it. When you flex your foot upwards, you point your toes upwards, you should feel that muscle contracting. That's what you want. And that's why you get the highest peak for that muscle, which is halfway in the middle of your shin bone to the right or to the left. It should be here, right? On this side. Any questions? And if you are doing, say, a parasomnia where the patients might be acting out their dreams, you should also use you'll also add the deltoid muscle. You will use the anterior deltoid, okay? You will attach the electrodes here. You just palpate it and put two electrodes at least 2 centimeters apart. And this will help you monitor the patient's arm movement, because sometimes they might not kick or move their legs, but they will move their arms. So you need to capture that. What you do is you just add a channel, an EMG channel in your head box, and then you add the anterior tibialis, not anterior tibialis, anterior deltoid muscle. Okay, any questions? Yes, no? All right, let's move towards EKG. EKG, we monitor the heart rate and also if there are any arrhythmias, right? The heart rate is important because it helps us understand whether this patient have any underlying condition. For example, you're about to start the study, the patient had been hooked up, you have all the sensors, they already rested, they've been in the sleep lab watching TV, but they have all the sensors. Now you want to start the sleep study. And then before you start the sleep study, you check all the sensors, you ask the patient to lay down, and then you will prepare for the patient calibration, right? So when you prepare for patient calibration, the patient should be laying supine and they should not be moving so that you can see if all the channels are working properly or if they're picking up the correct signal. But what you also need to monitor is the patient resting, right? And if the patient's heart rate is at 100 beats per minute, is that normal or abnormal? Yes, no? Is that normal or abnormal to have 100 beats per minute when the patient is laying down? No, patients shouldn't have 100 beats per minute. They're laying down and they've been in the sleep lab for some time. That means they shouldn't be stressed out. So if you notice that their pulse or their heart rate is high, check. Check. Always check the patient, right? Are you okay? Do you feel tense? Did you have coffee, that you shouldn't have had coffee, right? Or are they smokers? Usually smokers have pretty high heart rate because of the nicotine, right? So ask. And sometimes you get the opposite. Sometimes you have patients that are they actually have cardiovascular issues, or they are super athletes, right? You know what happens when you have super athletes or when you have like professional athletes? Their heart rate is really slow, maybe in their 30s, 40s. But ask anyway, because you're documenting. Everything is legal, right? Everything can be traced back to you as a recorder of what the patients are going through. So ask, hey, I noticed your heart rate is at 35. Do you feel okay? Or are you on medication that affects your heart rate? And then sometimes the patient will just tell you, oh, no, that's my normal because I used to run marathons all the time. So I'm very relaxed and that's normal for me. Okay. But you always check and then you annotate. You can annotate this in the chart. Patient asked about heart rate and patient mentioned that blah, 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 blah. Okay. Always ask questions, monitor anything that flags you, anything that gets your attention. Okay. Never skip any possible important information. Always annotate that into the chart. You know, it might not be a legal issue, but it could help the patient somehow. Maybe the doctor who might not pay attention too much on this patient's cardiovascular issues, but now since you mentioned something that might get the doctor's attention, that will make the doctor recommend this patient to be seen in cardiology, right? So we're trying to help patients here every night, not just recording for them. Okay, remember that. All right. Then we have the respiratory monitoring. Respiratory monitoring, again, we use two channels. Okay? We have to remember that we are in the sleep study, we are using what? We're monitoring two things. Okay? This is a good example. If you notice here, we're not just looking at the thermistor. This is a thermistor because it monitors the what? How does it monitor patients' breathing pattern? Anybody? How does
Detects the temperature changes, sir.
good detects the changes in the temperature, correct? So here, I don't know if that's what I heard you say, but this has a couple of wires sticking out. And usually we use copper, but those wires are sensitive to temperature. So when we inhale, the air is cold versus the air that's coming out from the lungs, of course, is warm because the lungs humidify and warm the air. So when it comes out, when we exhale, the air that comes out is warm. So that change in temperature creates the fluctuation and creates a sinusoidal pattern of breathing, right? However, the other thing that we measure is the pressure of the breathing, which we monitor through this cannula, right? This is the PTAP, or pressure transducer, airflow. It monitors airflow, right? Through the pressure of the breathing. And so you can have an absence of air, but it can still detect some pressure changes, right? So the patient can still be breathing, but very shallowly, right? And so when we monitor and score and read sleep studies, we identify, take note of this, we identify apneas, right? We identify obstructive apneas by highlighting the thermistor, right? This is typically known as the flow, okay? The flow or thermocouple or thermistor. We monitor apneas through the thermistor. That's an exam question also on the RPSGT exam. And we monitor and score hypopneas, right, through the pressure transducer or the PTAF. Okay? That's an exam question. And you have to remember, if you're the scoring tech, you cannot be scoring apneas on the PTAP. You score apneas on the thermistor. So for those sleep labs that only do one, they're missing the guideline, which is you have to have two. ASM, or American Academy of Sleep Medicine, this is mandatory to have two sensors for the flow. Okay? Questions? And then we also monitor two channels in sleep. Why do we monitor two channels in sleep? Anybody? Right? So usually the top part is your thermistor, so flow. Then the second channel is your pressure transducer. You see the difference? This patient still has some, it will still show flow on the thermistor, but then really low pressure of breathing. This is absent right here. But the third and fourth channel are typically your thoracic respiratory channel and then your abdominal channel. Okay. It is important because we use these two channels to see whether this patient is having central versus obstructive, right? During hypopneas, because this patient might still be breathing, but they might lose the volume, to lose tidal volume. They might become diminished. But then, if you're not paying attention to the thoracic and abdominal channel, you might miss out that this patient might have central hypopneas versus obstructive hypopneas. Okay? And I'll leave it like that for now, and we can get deeper further in the class, in the discussion. All right. Any questions so far? Everybody still awake? All right. Now, pulse oximetry. Next, we monitor pulse oximetry. Why? Because we have to find out the nadir, right? NADAR, nadir. Trying to figure out what is the lowest saturation for this patient. That usually signifies the severity of the patient's saturation. Is this patient losing a lot of oxygen? How bad is it? What is the hypoxic burden to this patient? Excuse me. Sorry, I hope you didn't hear that. So I'm coughing a little loud. Okay. So we're monitoring pulse oximetry. And how does it work? Anybody know? How does it work? Anybody? How does pulse oximetry work and give you 94%, 89%, 70%, 50%? Right? And it's just shooting on a red light. So pulse oximetry, it will shoot the infrared light, right, through the nail bed or through the finger, because the oxygenated blood cells will actually absorb more of the infrared, whereas the deoxygenated blood is absorbed more by the red blood cells. Okay, so there is a difference between the absorption of the infrared light versus the red light. Okay, so now the device will calculate the percentile of oxygenated blood compared to the deoxygenated blood and will give you a really good estimation of how much percentage is there for the oxygenated blood. I hope that's simple enough, but it's measured in percentile. Okay, so it monitors by comparing the absorption of the infrared light versus the red light, and then off that particular area where the light is penetrating, right, to the skin or the nail bed. So the point here is you have to use the bigger nail bed as much as possible. So you don't use the pinky, right? You use the middle finger or the ring finger, okay? So that you can have a bigger area of the nail bed that's being assessed. So you can capture more information, okay? Now, when you see that your patient has really low oximetry reading, let's say you start the study and your patient is at 85%. The first thing you need to do is to check your positioning, right? You check where the oximeter is placed on the finger, and you change to another finger. Okay? And then you go back and monitor and see what the reading is. If there's no improvement, no changes, you go back to the patient and move that oximeter to the other hand and make sure that the other patient's hand is not cold. Okay? Elderly patients usually, excuse me, you'll give you false negative for or false positive for being low in saturation, meaning to say you might have low reading because the patient have poor circulation, not because the patient is actually losing oxygen. So you have to troubleshoot first your position, okay, or the finger that you're using versus identifying that this patient is hypoxemic, right? Or hypoxic, whatever the case may be. Any questions on that? So, excuse me, my allergy is kicking in. Any questions, class? Yes, no?
None so far, sir.
Okay, good. I know it's late there, so bear with me. What is it? Oh, wow. Yeah, it's 11 for those in the Philippines. All right, we're gonna speed up a little bit, okay? Now, capnography, we use capnography mainly with pediatric, or if we're doing a sleep study and the patient has some form of hypoventilation, right? If the patients come in and they have a BMI of 40, 45, 50, so, and the doctor is worried, you know what? I think this patient might have obesity hypoventilation. So go ahead and do a sleep study and add a capnography. And typically we add the ETCO2. Again, ETCO2. Okay, for pediatrics, we use TCCO2. So instead of end-tidal, we use transcutaneous for pediatric patients. And we usually replace the TCCO2 halfway through the study because it becomes hot. Okay, for pediatrics, we attach it on the belly area. Okay, so it picks up CO2 through the skin, but then it gets hot. So we replace it halfway through the study. It's very expensive, and that's why it's not commonly used in adult sleep labs. But you can have a waveform or you can just have numbers. It will just show us numbers in your sleep study. Okay, it will just show, oh, 35 millimeters of mercury, then you can see it go up and down. Okay. Let's go to snore microphone. Snore microphones, they detect sound or vibration. They don't detect muscle. So just to be clear, it's not, but it's labeled as a usually EMG2, right, as part of the EMG channel, but it's not really an EMG collection. It's actually based on sound. So you put it right beside the vocal cords or the Adam's apple. Body position is often used and it helps detect identify where the patient is on the left or right side, but more so the scoring tech. Okay, it helps with adding the channel where the doctor knows that this patient is having more events during supine only, or because of this, the position sensor, the doctors can determine whether the patient had severe apneas, whether supine or lateral positions. Okay, very helpful. And sometimes if you don't have this, or this breaks a lot, especially with Philips devices on Alice 5 or 6, it breaks often. And so what ends up happening is we do the position manually. We actually add it manually on the channel. Okay. And the other thing, we monitor positions because of some patients might start to walk, and for them to be upright, it gives you a flag that, wait a minute, why is my patient sitting up? Especially if you lose your video monitor, okay, which is our next slide. So video and audio monitoring now is important because you can use this as a legal means to protect the techs and the patients. Okay, sometimes you have cases where the patients will say the tech touched me inappropriately, or the opposite, where the tech felt uncomfortable because the patient was aggressive. So having the, excuse me, a monitor for audio video helps create that atmosphere, whereas the patient and or the tech will be responsible for what they do. Okay, and so they become a little bit more cautious because they know that everything's being recorded. Okay. Types of sleep studies. Sorry, guys, I have to cough. My allergies kicking in. Ooh. Okay, types of sleep studies. We have level one. We call level one because it's done in the sleep lab and it's monitored by a technologist or a technician. Type 2 or level 2 are sleep studies with at least 7 parameters or more, but is not attended by a tech. So only level 1 or type 1 is monitored by a tech. Type 2, type 3, type 4 for home sleep testing, they are not monitored by techs. Okay? And HSAT, in home sleep testing, HST, are not monitored at all. Okay. And patients will take it home. There's a lot of different devices out there that I have a separate presentation on. Split night studies when we do at least 2 hours of sleep time for the patient before we put them on CPAP therapy or bi-level. Okay, split night usually is ordered if the patient has high chance of having sleep apnea or possibly have high AHI. Okay, typically we do a split night if the patients have at least an AHI of 30 or 40. Sorry, my Siri started talking. All right. Any questions on the split? No? Okay, good. All right. Patient setup. When we do sleep study, it's very crucial that we explain things to patient. The patient's night is comprised primarily of being educated. Okay, the patients must be educated appropriately and talked about their sleep procedure. Okay, we also orient them in the sleep lab. Where do you sit as a tech and where are the other patients? Where is the break room? Where is the bathroom, especially? Okay, and how can the patients reach you? How can the patients know, hey, if I need anything, do I call or yell or scream or press a button? So you have to educate the patient on that. And you have to explain to patients where you're going to put the electrodes or the sensors so that they are aware that you might be reaching over and touching them, right? Before you do so, it's very important to stay professional, educate the patients, orient them well before you apply all the electrodes. Impedance check is when we check in the system, in the sleep system, whether our placements and our electrodes, our sensors are still functional and are optimal. Sometimes the electrodes might appear okay, but when you check impedance, it's very high impedance. And that's when you realize that electrodes actually are broken or need to be replaced. Okay? We don't have calibration with the machine because now we are using digital systems. Okay, so everything is ones and zeros. It's become not like before where we used to use actual pens. All right. Are you all still awake? Are you all still
Yes,
awake?
sir.
Good. Because, oh my God, I remember these times. Actually, this is not old. I have a picture I took when I was in a sleep lab in Ohio, and this machine, I can't find it now. I'm going to show you an old machine, right? It's not showing. Sorry, guys. I'm trying to show you this. So these are all digital. The older machines. Oh, it's almost like this, but it's not. I have another presentation. Oh, there it is. Okay. All right. Can you see my screen?
Yes, can.
You can see this is an old sleep study device. Okay. As you can see, can you imagine? This is the pen. Okay. These are the pens and they fluctuate to create the signals, whether it's alpha, theta, delta range. It goes up and down like this. And that's based on the sensitivity setting that you put, the filters, the high frequency and low frequency setting. But this right here, can you see that little tube? This is a little tube. It's connected to this pump. This has the ink. You actually put ink in this. If you run out of ink, you open this top and you add ink. Okay? And then you pump it to make sure that the ink goes to the pen. And so you calibrate this system with the filter settings. And there's so much more. And this is a paper, and it comes from the bottom. It's a thick pack of paper, and it keeps scrolling forward, and it gets accumulated overnight. And that's how this doctors will read the sleep study. So before we used to calibrate this because you have to. You have to make sure that the pen deflection is appropriate for the sensitivity settings that you add, that you put. Okay? Nowadays, you don't have to worry about this. Everything's digital. I want you to see this because it doesn't make sense that what are we talking about calibration? At the end of the night, you will see a long pack of paper folded in half, folded, and the doctors read and by browsing to that paper. This is the outcome of that. Can you see it, guys, ladies and gentlemen? Are you guys glad that you don't have to do this? Imagine the work every day. I'm so messy because of all the ink that you end up on your lab coat, on your hands, on your, oh, name it. Sometimes you wipe your face, you don't know that you have ink. So anyway, I just want you to see. And this was still going on even towards the early parts of 2000. So you have to calibrate. Right now, you don't. Okay. What we do now is we calibrate with the patient, called patient calibration or biocalibration. We ask the patients to open and close their eyes, grind their teeth, move their legs, hold their breath, move their stomach, imitate a snore. So you're basically going to the different channels in your sleep study, right? Different channels to make sure that the sensors are picking up appropriately. All right, artifacts. That's when you troubleshoot the different issues with the sleep study. And we have a separate class on this. I will be discussing artifacts and we'll give you some examples. Some of you have already gone through that class, and so it's available in recording, but we will go to that class. And for those who want to attend the class in person via Zoom, message me. Otherwise, I will make the recording available for those who have seen it before but want to review. Okay? It's good for those who are practicing sleep studies right now or taking a test, as well as for those who are just getting into polysomnography. I want you to understand how to troubleshoot. What happens? Why do you have artifacts? What can cause artifacts? Okay, and how do you address it? How do you eliminate it? All right, scoring sleep study. This is, of course, at least 2 to 3 sessions, or if not more. Learning how to score is one of the most important skills that you can ever have. But you are not required to score yet if you are not licensed. Okay, usually you will be recording the studies, but you will not be required to score sleep studies because you don't have the RPSGT yet. Once you have the RPSGT on your name, that means you can be a scorer, right? I have a few techs that used to be my students and became my staff in the Philippines. Now they're abroad. They started as scoring techs for different companies in Canada, the UK, or US, and now they are in different countries. You can do the same. Respiratory events. We monitor sleep stages with the EEGs. We monitor respiratory events with our flow. We mentioned earlier the thermistor, the P-tap or pressure transducer, and the respiratory channels to identify whether the patient is having an obstructive event, a central event, or a mixed event, a mixture of obstructive and central. Okay, typically mixed events start with central, where you don't have effort and you don't have flow. And eventually the effort comes in, but there's still no flow. So that is a mixed apnea. And the key to all these events is that they need to last a minimum of 10 seconds. If it's only 7 or 9 seconds in total duration, you cannot call it an event. Okay? Cardiac events, we also have a deeper dive where we will study and discuss about atrial fibrillation, atrial flutter, premature ventricular or atrial contraction, of course, VTAC, etc. Now, when we integrate and put everything together, This is now the polysomnogram, right? This is now the polysomnogram, the entire recording comprising from the EEG, EOG, EMG, EKG, respiratory channels, including the additional parameters such as your titration, right? We can be doing CPAP titration, so you have a CPAP channel or C-flow channel. Then we can also add the oximetry, which is mandatory, or you can also add the supplemental information on CO2 monitoring, capnography. When you have pediatrics or patients that might have hypoventilation syndrome, then you can add a CO2 monitor at the bottom. You can really rearrange this the way you want it. Most of the sleep system, if you have this montage or the arrangement of the channels this way, you want to change it, right? Let's say I want my EOGs to be on top. Most of the sleep system, you just click and drag. Oops, sorry. What you do is you click and hold this channel, LOC. You click and drag it on top, then it moves there. And then you move the ROC, right? You can rearrange it. When you right click, you can also change the colors. You don't have to just have all black or red. I like the EKG in red. I like the EOG in blue, right? EEG in black, and some of the respiratory channels, I change it to different colors. But it's up to you, right? When you're scoring, you can click and drag and it highlights that event. Okay? But we can go through that in a different class. All right. So role of the sleep tech is we monitor not only the study, but we monitor the patient's safety, especially for pediatric population, especially for geriatric population, and also patients with special needs, such as seizure patients. We make sure that the bed rails, if we are in a hospital, that the bed rails are up, that the patients who we expect to be sleepwalking, that we closely monitor them. If they are trying to get out of the bed, we have to make sure that we open the door, get to the patient, and ensure that they don't hurt themselves and fall off the bed. Okay? And we monitor the quality of the data, the recording. And that's why we will teach you how to prep 1020, how do you troubleshoot, and make sure that how the sleep study looks like after you're done recording is appropriate and very clear for the doctor and the scoring tech. Okay? And of course, the documentation, not just on paper, but what happened throughout the night. Any of your observation has to be put in the chart or in the patient's recording, okay, including the audio video. All right. Then accurate reporting, you never doubt yourself from documenting. Always document. Okay, you can never have too much documentation. If you lack documentation, that's a problem. If you have a lot of documentation, that is not a problem. That's good, okay? Because anything medical is legal. Again, anything medical is what? Is legal documentation. So it's very important to be proactive in your note taking. We have now wireless sensors, we have machine learning, we have AI that are auto scoring, especially home sleep testing. And then we can also monitor patients' usage of their CPAP machines, bi-level machines at home. Here in the United States, I can go on AirView by ResMed, and I want to check all my patients or one particular patient that is having a hard time with their CPAP machine. I can check online whether they used the machine last night, whether they were leaking, whether they are having any residual apneas, and whether I want to change the pressure. I'll just call my doctor and say, hey, doc, this patient is still having obstructive events. Can I increase the auto CPAP from minimum of 4 to 8? So imagine all these capabilities now. That did not exist before. Now you can literally change pressure without leaving the office and the patient is not coming into the lab. You can change the pressure while they're at home. All right? Can you imagine the changes now? All right. Then the challenges, of course, for us is the patient compliance, whether they're in the sleep lab and they hate the CPAP that you just put them on and they don't want to do it. So what are you going to do? And when this happens, usually we annotate saying we try to educate the patient that they need a CPAP, but they refuse after experiencing it. They're having a hard time breathing, blah, blah, blah. So explain what happened, right? And then you can put the patient back on just diagnostic. Okay, take off the CPAP, put back the nasal thermistor and the nasal pressure transducer, and just continue recording for diagnostics if the patient do not comply with a split night or titration. All right. And of course, fatigue. We work at least what, 10 to 12-hour shifts, right? And sometimes we are requested to extend our shifts in the morning, which is very difficult. I always ask my techs to clock out at 6 a.m. They're done. If they have to add any extra minutes or so because they're waiting for the patient, that's okay. But I always want to ensure that our techs rest at least 8 to 10 hours between shifts. Okay, they are protected here in the US by law. In other countries, I know that doesn't exist. I know some of you techs are working 16-hour shifts and still asked to rotate to days and nights within 1 to 2 week period, which is horrible for your sleep health. So anyway, I want to conclusion, right? We're finishing up. We got to the end of this. So congratulations to everyone. Now we need to understand that polysomnography is a comprehensive diagnostic tool, all right? And then it's also a treatment tool because we do titrations. We do titrations not only with PAP therapy, okay? That's the gold standard for treating sleep apnea. What is it? It's the PAP therapy, positive airway pressure, gold standard. You have to remember that for examination purposes, RPSGT exam, or for just your knowledge as a sleep tech or going into sleep. The other types of interventions we use are oral appliance, surgical interventions where we cut adenoids or uvula, uvula palatopharyngoplasty. We put pillars, we expand the maxillary expansion devices, and we do other things with patients to intervene or to correct their sleep disorders. Okay. Now, we play a key role in these patients' experiences, patient diagnosis, treatment, and clinical management because we can provide the different parts of services that a sleep clinic or a sleep lab needs to provide for patients, not only during their diagnostic, but also during the treatment and the years of clinical management. Remember that most of the sleep disorders patients are suffering from chronic disease, particularly those with sleep disordered breathing problems, right? When you have OSA, you don't eliminate that in 1 day or 2 weeks or 2 years, right? It depends. But for the most part, it's a chronic disease. And so it is important for us to have an ongoing training. I've been in the sleep field for 25 years and I'm still learning new things constantly. The sleep medicine is evolving. It's rapidly growing into the AI era, right? Into large language models. So many computerized developments are happening, particularly with the diagnosis and also with the scoring portion of sleep medicine. On that note, let me stop my share. I want to ask if there are any questions and if all of the information I provided here are clear or unbiased or any mistakes, please don't hesitate to ask and we can clarify, elaborate, and further guide you to this whole training program. All right. Class, still there? Still awake?